times staphylococci. It is usually tender with edematous margin, well demarcated margin. And cellulitis, when the infection goes deeper, mainly streptococcus, again staph, and the margins are diffuse and it is usually associated with some systemic complaints. What is more concerned is the emergence of methicillin-resistant Staph aureus disease. That's why we are concerned about the therapy of the skin infection. Sorry, I'm not able to. So what is impetigo? Impetigo is superficial bacterial infection, either it is bullous or non-bullous. Bullous are mainly by Staph aureus, and non-bullous either both Staph as well as streptococci. The non-bullous are most common, 70% are non-bullous impetigo, and usually it starts with a vesicle of pustules, rupture easily, and followed by yellow-colored, honey-colored crust, then spreads contagiously or by autoinoculation to the other skin areas. By the bullous impetigo, it starts as a flaccid bulla which rupture easily and leading to moist erythematous base with colorata of ruptured bulli. And the boils are deeper infections, and carbuncles are cluster of boils which are connected by sinuses. They are tender and painful. The folliculitis, as I told you, it is by Streptococcus, but sometimes other organisms like gram-negative Pseudomonas are also involved, but they are a rare condition. And the cellulitis erysipelas involve the subcutaneous tissue and epidermis. As we see, the prevalence of skin infection varies from country to country. In an Indian study published in 2015, most common are fungal infections, that is Kenya versicolor, the most common, followed by viral and impetigo. So what is the rationale? The bacterial infection develops when bacteria enter through air follicles or through small cuts. There are punctures, surgery, chickenpox, burns like that, or insect bites, very common, papular urticaria, followed by secondary infection. So what are the current treatment options left with us? Either it can be topical or systemic. So when to use topical? Topical therapy used when we have limited number of skin infection, localized, superficial, then only we can use topical therapy. But whenever any doubt, or if your doubt of streptococcal infection, or there are systemic symptoms, or significant lymphadenopathy, lymphangitis, it's better to go for systemic therapy. Depending on the severity of the disease, you can go for either oral or parenteral. As we see, impetigo is caused by both staph as well as Streptococcus pyogenes. So it's mild or local disease. You can wash the crust and apply topical mupirocin or fusidic acid, which are available also the datapamulin acid. But if the lesions are multiple or they are recurrent disease, then we have, or if there is epidemic, then we have to use oral or systemic therapy. The most common drugs which can be used for oral therapy is cephalexin in the dose of 40 to 50 milligram per kg per day, and dicloxacillin, or if a substitute of MRSA, we can use clindamycin or thimerosal plus sulfamethoxazole. But not mentioned in this slide are cephalodoxil. Cephalodoxil, from my experience, is a very good oral therapy for superficial skin infections, 30 mg per kg per day for 7 to 10 days. And very well tolerated, and I'm using for last 23 years. But the boils and carbuncles, if limited, we can still go for the oral therapy, but a single big boil or abscess, incision drainage is the first step of therapy. We can send the first for culture, and as per the culture reports, we can change our therapy. But any doubt of MRSA, severe infection, septicemic condition, it's better to go for IV with vancomycin or clindamycin. Same applies for folliculitis, but for cellulitis and erysipelas, we have to look for the general condition of the patient first, because they may have septicemia or other systemic involvement. We may have to admit, look out for the ABC, IV fluid, general supporting measure, and it's best to start, before you start any antibiotic, please send the first for culture either by percutaneous needle aspiration or by incision and drainage, and followed by therapy. If it is mild disease, you can go for again oral for 7 to 10 days. If severe disease, better to start IV, either cefazolin, vancomycin, or if as per the culture report, we can change our therapy anytime. As we see, impetigo is the most common bacterial infection between 2 to 5 years of age, but at any age, including neonates, we can see 1/3 of the infection in the skin is attributable to impetigo, most common by the mosquito bite or staph. What happens is staph and streptococcus. Streptococcus is not usual commensal of our skin, but staph is residing in our nares and ear lobules or behind the ear, and with scratch they can introduce to the broken skin and start the skin infections. So it can be primary or secondary depending on the whether it's secondary to some scratch or cut or burns like thing. As already mentioned, non-bullous are the most common, 70%, caused by both streptococcus as well as staph. It can be primary or secondary. Secondary is a bacterial, and it starts as a macropapillary lesion, then moves on to honeycrust, typical honeycrust of the lesion. While bullous type is only staph aureus. Sometimes it dissolves with 2 to 3 weeks, but no scarring both impetigo, and are usually seen in buttocks or the groin areas or folds. Systemic symptoms are uncommon in both bullous and non-bullous, but in non-bullous impetigo, up to 70-80% we can have lymphadenopathy and leukocytes in up to 50%. While post-streptococcal glomerulonephritis is common, very uncommon, usually 2 to 3% with streptococcus nephrogenic strain of streptococcus pyogenes infection only. But rheumatic fever is not seen with impetigo. So as I have already discussed, intact skin is usually resistant to colonization by staph aureus or GABs, but they can be introduced from environment, usually secondary to some scabies or chickenpox or other scratches, pediculosis, surgery like thing, or sometimes in intact skin if they are immunosuppressant, either by some disease process or by medication. The impetigo is the most common bacterial skin infection and the third most common skin disease, and usually 10 to 25% clinic visits are sometimes seen with are because of the skin infections. So what are the treatment options? As I already told, it can be topical or systemic. Topical antibiotics are more effective than placebo, and it's seen many studies have been there. Latest was seen in 2015. They are seeing that topical antibiotics is superior to the placebo. They can dissolve spontaneously, but if you give topical antibiotics, the cure rate can be up to 60 to 70%, as placebo medicine only 25 to 30%. And the antibiotics systemic are reserved for severe infection or generalized infection. So topical antibiotics, we all know the advantage because minimal side effects, cost effective, and it is applied only when needed. So what are the topical antibiotics we have? Our age-old mupirocin fusidic acid and newer entity, the datapomulin. Fusidic acid available at 2% ointment as well as cream. It is applied to skin 3 times daily for 7 to 10 days. Mifepristone, both cream and ointment both are available. Approved only above 2 to 3 months of age. Again, 2 to 3 times daily for 10 to 7 to 10 days. But any topical therapy re-evaluate after 3 days. If not improvement, go for the switch to oral or parenteral antibiotic as per the need. Retapamulin, only one company I know. It is again 2 to 3 twice daily for 7 to 10 days. But whatever topical therapy we give, it has to be applied only when there are limited number of lesions. That does not exist 100 centimeters for adults or 2% of total body surface area, and for mifepristone more than 2 months of age, for retapamulin 9 months. If any doubt of any systemic infection, any doubt of streptococcal infection, better to give systemic antibiotics as well. So let us go through the treatment part. Look at the impetigo. If any systemic signs, symptoms, sickness of the child, educate the parents about the general hygiene, trimming of the nails, washing, frequent washing. If it is localized, more than 2 months, less than 36 centimeters square, less than 10 vesicles, immunocompetent status, just clean the skin, remove the crust, and apply antibiotic, either mifepristone or fusidic acid for 7 to 10 days. But if any doubt, if any fever or systemic symptoms, a mild disease, better to give antibiotic oral, or if any type of streptococcal infection or epidemic situation, start oral antibiotic in the form of either cephalexin, cephaloxil, or if you think that there are more of a streptococcal origin, lymphadenitis, better you can go for arolemoxiclav or clindamycin as well. If no improvement 3-4 days, the child develops any other systemic symptoms, you can admit anytime through culture sensitivity and start parenteral therapy. Same thing. The ICMR guideline says impetigo must stop and stop. The first line oral antibiotic is the clindamycin or amoxiclav. And in local, if the guidelines, as per the guideline, we can go for mifepristone. The resistance to fusidic acid vary around 50 to 60%, and the resistance to mifepristone in MRSA other is from 5% to 31%. So as we know, mifepristone fusidic is used for long. Retapamulin is recent alternative. Both mifepristone and retapamulin are bacteriostatic at low concentration, but may be bactericidal at higher concentration. While fusidic acid is reported to bactericidal for Streptococcus pyogenes and bacteriostatic for Staph aureus. And as we see that the mifepristone resistance is increasing, this is USA study. In 2009, they are 5% resistant to the mifepristone, but it has increased from 31% to 80%. While one study in European country recently, they have seen 5% resistance in France to mifepristone acid and up to 35% in UK. As a result, there are many newer treatment options are available now. So the new molecule OZENOXACIN has come up. So what is OZENOXACIN? It is a topical non-fluorinated quinolone. Because it is non-fluorinated, non-halogenated, the systemic side effects are very, very rare. It is non-observable. It is bactericidal as in gram-positive, including MRSA, methane-sensitive, methane-resistant Streptococcus epidermidis, Streptococcus pyogenes, and mifepristone and Streptococcus resistant of Staph aureus. How it acts? It acts by inhibiting dual action, by inhibiting both DNA gyrase and topoisomerase 4, which are both involved in bacterial DNA synthesis. So because of dual inhibitory activity, it avoids the development of resistance. Both these three, OZENOXACIN, mifepristone, fusidic acid, they all act by inhibiting protein synthesis, acting at various levels. Because OZENOXACIN acts against the both DNA gyrase and topoisomerase 4, it's resistant to resistant mutants. resistance to OZENOXACIN very less. And the MIC against both streptococcus and staphylococcus is very, very low as compared to other topical and systemic antibiotics. As we can see, I will not go through details of this, but it shows high in vitro activity against all staph isolates, almost 99.4% with very low MIC. So the same is compared to that. This is what in 2019 study, which can show OZENOXACIN at 2 times the minivit in the MIC, showed bactericidal activity, whereas mifepristone and fusidic acid equal to 32 times of the MIC. So very, very effective against many strains of staph as well as staph. And with even with a single application, it has showed 53% eradication rate as compared to 31% retapamulin and 28% for fumigation. So it can be applied for 2 months of age and older, and so estimate of as I told, is both gram positive, like both mifepristone resistant as well as MRSA, fusidic acid resistant, quinolone resistant staph, and clindamycin staph aureus as well. It has to be applied twice daily for 5 days. Please do not go longer than 5 days because there are chances of super infection with other bacteria and fungus infection if you go for longer therapy with OZENOXACIN. But as it is a newer therapy, still the guidelines are not very, very sure about it. We have not come up with guidelines against about OZENOXACIN. Many studies are shown its superiority, but recent study meta-analysis still shows, many studies in USA has been done that OZENOXACIN is not superior to our age-old mifepristone. So still mifepristone holds the court unless we are really concerned about resistance to the mifepristone, which is still very low, around 3 to 4%, sometimes 8% only, at least in India. But we don't have data from India. So it has to be applied with a very thin layer or to the affected area twice daily, maximum area 100 centimeters per adults, and less than 12 hours can be applied only to the 2% of the total body surface area. It can be covered by sterile bandage or gauze. If re-evaluate the patient, if no improvement 3 days, re-evaluate an alternative therapy, whether it's oral or parenteral. So the key message, OZENOXACIN is effective against both streptococcus or staphylococcus, including MRSA. It's a very low potential to generate resistant mutants with negligible systemic absorption rate, approved for patients from 2 months of age, and very convenient dosing twice a day for 5 days. As I can tell you, the activity of all these topical antibiotics, mifepristone, fusidic, OZENOXACIN, they are very much enhanced if the pH of the skin is kept low. If it is pH, as the pH comes down from 7.6 to 5.5, the growth of bacteria is significantly inhibited, and there is very enhanced level of antibacterial activity of all these 3 antibiotics, mifepristone, fusidic acid, as well as OZENOXACIN. I will not go to the details of this, but as the pH goes down, the MIC of this does lessens. And the zone of inhibition also shown in vitro. So acidic pH has shown to improve the active fusidic acid also. I will skip all these slides, the same thing. How it works, the bacteria has a pH gradient across the cell. The inside the bacteria is alkaline. So when they are exposed to the acidic pH on the skin, the alkaline pH inside bacteria further increases. So the diffusion of antibiotics into the bacteria increases. So antibiotics are more effective when the skin pH is low. So the impinos adapt as a newer skin syndate, which gives the Elastap, that is normalizes skin pH, it is a potential topical antibiotic, and also it has shown to inhibit the staph aureus growth. Thank you.
Thank you, Dr. Halwai, for the nice and very much elaborative session.
I think I was very fast. As advised by sir, I did it very fast. But thank you. Probably I completed in time.
Sir, there are few questions in the chat box. Sir, Dr. Suvasrikar has asked, can we give amoxiclav in impetigo or local cellulitis, oral amoxiclav?
Yes, that is very good option. If there is any doubt of cellulitis, it's better to give oral amoxiclav. Amoxiclav is better. It's very good activity against both streptococcus as well as staph aureus. But if there is localized infection with lower systemic sign symptoms, it's better to restrict ourselves to either cefalexin or cefatoxin, because to avoid the resistance pattern and the better tolerability. If you localize minimal symptoms, cefalexin or cefatoxin. If you see the symptoms are more, you can go for amoxiclav.
What about erythromycin?
Why we wanted this topic?
Erythromycin is good for streptococcal only. Streptococcal only. Erythromycin, they have evaluated with mupirocin. It's not superior to the local mupirocin. Erythromycin, old drug resistance is getting higher, and tolerability is also an issue with erythromycin. Erythromycin good for streptococcus only, but we have to reserve that drug to many other conditions to avoid resistance.
Thank you. If there is no other infection question, then thank you, Dr. Halwai, for the exhaustive presentation. Dr. Lal is there? Hello, Dr. Lal. My co-chairman is missing, so
can you hear me, sir?
Yeah. Then you take over and introduce Dr. Gupta and start the meeting.
Hello.
Hello. You take over, Dr. Lal. Introduce Dr. Gupta and start the meeting.
I don't know his introduction. Dr. Ravi Kumar.
You have got the intro, or I'll introduce him?
Sir, you introduce and I'll just say a few words, sir.
Okay, okay then. Dr. Gupta, you are there?
Yeah.
Hello, Dr. SANDIP GUPTA. Yes, you are very much welcome to our webinar, all the long way from Bangalore. We welcome you heartily. Dr. Gupta has got a 4-page curriculum vitae. If I continue to read that, it will consume a lot of our time. But to briefly introduce him, he is an MBBS, MD, done his fellowship in pediatric intensive care. Present job assignment is he is a senior pediatrician and pediatric intensivist in Esther CNI hospital in CMI hospital in Bangalore. He has got extensive 6 years post-MD experience in pediatric intensive care. He is a known faculty and person in the management of pediatric critical care. With these few words, I hand over to Dr. Lal to speak a few words, after which we'd like to eagerly waiting to hear Dr. Gupta. Thank you.
Good evening and welcome to all of you. I'm especially thankful to our speaker for joining this webinar and educating us on NIV in pediatrics. As pediatricians and neonatologists, you are all well aware of our practice of NIV in neonates. However, this concept of NIV in pediatrics is relatively new, and with this onset of the third wave, which is going to affect children, and more NIV will be probably required in children as it has happened in adults. I was surprised to see high flow ventilation being used frequently in adult and COVID patients here in most centers, which has been probably a takeoff from the high flow ventilation we are doing in children. So we would be very eager to hear all about NIV, especially in relation to COVID, which might present to us in a form in which we might have to ventilate these babies in with NIV. So over to Dr. Gupta for carrying out his talk to us.
Thank you, Bijay sir, and thank you, sir, for a nice introduction. So I'll start by saying that COVID has actually brought in front the respiratory management in all perspective to become more prominent, and different modalities have been used to manage COVID in depending on the severity of the illness. Can you hear me? All of you can hear me?
Yes, yes, you are audible. You are audible.
Yes. So what I have experienced, because having worked in many centers in across India, in West Bengal and Delhi and Bangalore, so I keep in touch with adult intensivist and pediatric intensivist, and I am a part of the ECMO Society of India also. So I've seen like patients of different severity being managed in different way, like right from requiring some minimal oxygen to high flow nasal cannula to non-invasive ventilation to actual ventilation and proning to ECMO and HFO. So all these are the spectrum of like what respiratory support we can offer as an intensivist and as a pediatrician. So these are all very important, and NIV fits in between these things. So between like simple face mask driven oxygen. So simple face mask driven oxygen, then comes the high flow nasal cannula, and then NIV, and above NIV sits the intubation and mechanical ventilation, then high frequency ventilation and ECMO. So this is the range of services in terms of respiratory support we can offer. So now I'll start with the presentation. So basically the topic is non-invasive ventilation in the light of COVID-19 infection, how to like go about doing non-invasive ventilation. So first of all, I would like to say that non-invasive ventilation is basically a support which actually helps us in managing mild to moderate cases. And today I'll be talking more in details of non-invasive ventilation, and the use of non-invasive ventilation in all cases is more or less same, but there are subtle differences in how we can use them. So today, okay, are you all able to see my presentation?
Yeah, very good to go.
So we'll discuss about the concept of NIV. How does it work? What are the different types, ways or types we can use NIV? What are the indications and contraindications? What are the complications we can encounter? And what are the interfaces? So different masks which we use, just like how we use ET tube for intubation and mechanical ventilation, similarly, we use certain amount of masks and circuits for non-invasive ventilation. And then finally, I'll give you an idea as to what algorithm we can follow to manage our NIV patients. So let us start by saying what is NIV. So NIV is basically, it's a method of delivering the ventilatory support without the use of an artificial airway. So in the artificial airway, the most common is the endotracheal tube, but there is laryngeal mask airway and tracheostomy tube also, which are actually artificial airways. So whenever you don't use the artificial airway, you just give support by nasal or mouth or both oronasal mask and somehow by nasal prongs. So these things come into the prerogative of non-invasive ventilation. So common uses is hypoxic respiratory failures like ARDS, pneumonia, aspiration, even sepsis patient, and diseases where the patient may have hypercarbia. So which are not actually alveolar pathology, but there is neuromuscular weakness or there is obstructive airway pathology. There also NIV can help. And in patients who require chronic support somebody on obstructive sleep apnea or neuromuscular disease who require support for longer period of time, in that ventilation is not, invasive ventilation is not a good option. There comes the role of non-invasive ventilation. So today I will try to focus on what is the acute use of non-invasive ventilation. Just to include everything, I'll just touch upon the other things. So the technique of application of non-invasive ventilation has been in a very, like 60 years back also, in the time of polio also, we used to have iron lungs. So that created negative pressure around the chest and it used to cause ventilation. Then came the cuirass. You can see a picture that is like a shield on the chest, which again creates a negative pressure and lets the patient get inspiratory breath. But these are non-invasive negative pressure ventilation. So these are very rarely used and currently it is not practiced in normal scenario in usual hospital. Only research facilities and certain amount of specific centers abroad, they are using it. What we use is non-invasive positive pressure ventilation, which is the current standard and practiced in most of the ICUs. So before going to the actual NIV, we can just look at the physiology of pediatric airway and pediatric respiratory problems. So what happens compared to adults, pediatrics have a smaller airway. So they kind of get diseases like bronchiolitis or asthma more, where high airway resistance is there and workup breathing is the main problem rather than the hypoxia. And if you look at the pediatric chest wall, that is a very compliant chest wall, so it cannot hold on it. So what happens is whenever we breathe, the negative pressure is generated by the two pleuras, the negative pressure inside the two pleuras, visceral and parietal pleura. So visceral pleura is attached to the lungs and parietal pleura to the chest wall. So negative pressure creates the inspiratory drive. So that is again because the chest wall is very compliant. So children have very low FRC, and that causes excessive workup breathing. And early in infancy and early childhood, diaphragm is not a very strong muscle. And as we know in adults, diaphragm is the major respiratory muscle. So these factors actually put the children at higher risk of respiratory illnesses and more severe illnesses compared to the adults. So their strength to fight respiratory problems is less. So now discussing about the NIV. So how do we look at NIV? So how does it work? So what happens is NIV gives some positive pressure at the oral or nasal interface, and it maintains airway pressure and PEEP. So PEEP we understand is positive end expiratory pressure. So at the end of expiration also it ensures there's certain amount of pressure in the alveoli. So you can see in the picture how the PEEP actually helps to keep the alveoli open. And if you keep on increasing PEEP, what happens is certain amount of closed alveoli, which are partially consolidated and partially filled with fluid, they may open up. So this is something we call recruitment. So recruitment in the sense the alveoli which were previously not functioning now are opening up because of giving PEEP. The recruitment is a more prominent thing which happens in actual ventilation, invasive ventilation, but it also happens in NIV if you give certain amount of PEEP. So what it does is when you open up more alveoli, better air exchange happens. So better delivery of oxygen to the blood happens, as well as better clearance of CO2 happens. And because PEEP is causing opening of the alveoli, the stiffness of the lung, the compliance of the lung improves. So which helps in the better workup breathing. So workup breathing reduces, right? So now it is helpful in reducing the workup breathing and improves both oxygen and ventilation. So how it helps is it helps the diaphragm and the accessory muscles unloading. Means the workload on the respiratory muscles is very high in a non-compliant lung or in lungs which is having airway obstruction. So it reduces those workload and reduces the inspiratory energy expenditure, as well as it stabilizes the chest wall. So the PEEP actually helps the chest wall to stay firm. So reduces the amount of retractions. Okay. And again, as I said, PEEP helps in the opening of the alveoli which were previously closed. Sometimes what happens, certain patients will have hypoventilation because of the muscular illness or muscular weakness or obstructive apnea and all these things. So in that case also, it stabilizes the airway and it helps in preventing the obstruction and minimizing the obstruction. So better clearance of PCO2. So this is how it helps. So this is the mechanism how we see the NIV working. So now how do we, why do we need NIV? So we can do all whatever I said by doing a invasive ventilation, right? So why do we need NIV? So NIV actually has multiple benefits when we compare it to the invasive ventilation. First is invasive ventilation is a very painful procedure. So whenever you put patient on ventilator, you need to give analgesia, sedation, as well as it's a one-sided thing. So the moment you intubate, then you cannot extubate at your will. The patient has to have the resolution of the disease pathology, then only you can extubate. Whereas NIV is very like you can try for some hours and then you can just remove like a face mask. So how we are using face mask for COVID, and then again we can remove it when we are at home. So that same thing can be done with NIV mask. You can use it for 6 hours, 4 hours, and then can give a break for the patient. So which is very easy to do. Again, it improves a lot of things. So you don't have to sedate the patient. So the patient is awake and alert and he can interact. And it is much easier to give care to a patient who is on NIV compared to invasive ventilation. As you know that ET intubation, endotracheal intubation has very high risk of ventilator-associated pneumonia as well as ventilator-induced lung injury. So both the like adverse effects of ventilation is not there in NIV. So in NIV doesn't have to put a tube inside our body mucosa. So when you put a tube inside the body mucosa, it is a foreign body. So any foreign body put in the body will cause a risk of infection. So in ventilation, if you prolong ventilation, any ventilation above 7 days increases the risk of severe infections in the lung. So VAP. So ventilator-associated pneumonia is very common. So to prevent that, NIV is very useful. So in NIV, you are not putting any side inside the body. So there is very less risk of infection due to NIV. Similarly, the ventilator-induced lung injury is not that prominent in NIV. Whereas in ventilation, invasive ventilation, you have a very high risk of ventilation-induced barotrauma and volutrauma. Then what happens is, because NIV is a method where you're not putting the patient under sedation and paralysis, and patient is not like unconscious, it definitely reduces the ICU stay as well as mortality and decreases the cost also. Sorry. So the potential cost of invasive ventilation compared to non-invasive ventilation will be almost only 25 to 30% of the cost of invasive ventilation. So I have worked around many hospitals and many ICUs in India. So around 20,000 cost comes when you put a patient on invasive ventilation, whereas NIV is very cheap. The basic machines which we use in our ICUs may come in 2 lakh rupees, and the operating cost is also very less. So in practical, these are the use benefits, and we see more and more use. Hello. So more and more use of NIV nowadays in early weaning. So what we are doing is, when patient is ready to come out of the ventilation, even before that, when we want to wean it on a little bit moderate settings, also we can take the tube out and support the patient for like 6 to 12 hours or a day on NIV. So this is how we are doing it. It is facilitating the patients to come out of ventilation early, or it is preventing re-intubations. Previously, what used to happen is, those patients who were intubated after extubation, if they had respiratory distress, we had to go through the trouble of re-intubation. So re-intubation actually increases the risk of infection and a lot of other problems. But nowadays, what happens in our PICUs, what we do is, once the patient is extubated, if they have mild to moderate retraction, mild to moderate hypoxia, we can just put them on NIV and carry on. So I hope the message is clear. It is very helpful in preventing intubation and re-intubation. It is very caregiver friendly, less amount of care, less amount of cost, and has less side effect compared to the non-invasive ventilation. So now potential indications for NIV is hypoxic respiratory failure. So COVID, what we see is mainly there's hypoxia. What happens is PO2 levels drop without even noticing enough amount of worker breathing or distress. So that is kind of a silent hypoxia happens in a COVID scenario. So which is very much a situation where we can use NIV. NIV has been very useful in my practical experience also. We have managed most of our patients by doing NIV. Similarly, hypercarbic respiratory failure, we can actually increase the ventilation by supporting the respiratory muscles through the pressures in the non-invasive ventilation, and we can make it easy for patient to breathe and wash out the PCO2. As I said before, peri-extubation means, like, if after extubation we can support the patient, and even if the post-extubation patient is having respiratory distress, that can be also helped by NIV. Difficult weaning patients also, they are supported for a long time on NIV, whereas doing long time ventilation, invasive ventilation is very difficult. Diseases like GV syndrome, myasthenia gravis, where muscular weakness is there also NIV is very helpful. Another aspect of NIV is it is very useful in patients who are immunocompromised. So now I work in bone marrow transplant unit, liver transplant unit. So these units, what happens is, if you intubate, they are totally immunocompromised because they are on multiple chemotherapy and immunosuppressive drugs. So they can get very bad infections and resistant bugs. So we try to avoid the intubation as much as possible, or the try to limit or reduce the number of days we have to keep them intubated. So in that, the NIV is very handy. It is very useful to like a patient who is having moderate or to mild distress or hypoxia, respiratory distress or hypoxia, they can be put on NIV. Similarly, asthma is a very nightmare situation for an intensivist to manage on invasive ventilation. There also it is very handy, though there is not enough evidence in terms of asthma in pediatrics to support the use of NIV. But from my experience, we have used many times and it has been very effective in preventing intubation. Because asthma, when you intubate, there's a very high risk of pneumothorax. So now I'll come to the business part of the talk. So now, how do we actually give NIV in our hospitals? So here are a few methods how we can give NIV in our hospitals. So if you don't have a specific NIV machine and you only have a ventilator, so still you can give NIV. So every ventilator nowadays, modern ventilators are having NIV modes. So these are called NIV modes. You can, when you're setting up, you can go to the NIV mode and you can give NIV through the ventilators. So GE ventilators, Mackay ventilators, all are having NIV mode through which you can give. So I may share the link if you want how to do NIV from the ventilators. Then there is there's another form of NIV which is we call CPAP. So bubble CPAP, all of us we have used. I have kept the picture on this slide only. So you can see this bubble CPAP. All of us are using this in an NICU setting, and sometimes it can be used in older patients also. In PICU setting we use. So just things like BPD and all, when the children are like in infants or 2-3 year old, when they come with these problems, we use CPAP alone. Then there is something called high flow nasal cannula. So high flow nasal cannula is kind of a modification from the previous nasal cannula. So previous nasal cannula, we could not give more than 4 liters of oxygen per minute, and we could not give because of the dryness of the nasal mucosa. So if you give very high flow oxygen through normal nasal cannula, the nasal mucosa will become dry. And another problem with the conventional nasal cannula was you could not measure how much FiO2 you are delivering through a normal nasal cannula. So that's why something called high flow nasal cannula has come. So high flow nasal cannula actually gives humidified as well as a fixed amount of FiO2, and you can give very high flow. So by high flow, I mean, even if you want 100% oxygen to be given, it can be given. The amount of oxygen delivered can cross the minute ventilation of the patient. So that is why we call it a high flow device of giving oxygen. So high flow nasal cannula, another advantage is it can provide a limited amount of PEEP. So it may help the stenting of the upper airways as well as opening up the alveoli to a limited extent. So we don't know exactly how much PEEP it will provide, but it certainly provides some amount of PEEP to keep the alveoli open. And from my experience and the centers where I worked, and I know people all around India, HFNC is actually the go-to for most of the patients in early stages of the disease. Even COVID patients we have managed with HFNC very nicely, and it has been very useful. So in mild hypoxia, in mild respiratory distress, and diseases like bronchiolitis and all, it works like magic. I think some of you definitely would have used HFNC, and it is very useful. And it is one of the best advantages of HFNC is it is user friendly, both for the nurses as well as the patient finds very comfortable to use HFNC compared to even CPAP or NIV or invasive ventilation. So it is one of the most easiest and comfortable respiratory devices, and it helps. It is one of the best used oxygen delivery devices, I would like to say. So HFNC is now very rapidly picked up. When I started PICU training in 2015, it was just getting started. So the only few units in India had, but now almost small centers also, those who don't have PICU also are using HFNC. So it has gained a lot of popularity in the last 5-6 years. And I have definitely seen the rise of use of HFNC, and because it's very easy to use and the learning curve is very small. So you can learn very fast how to use HFNC, and it is very useful in pediatric patients especially. So now we come to the most important like NIV device. There is a customized NIV machines. So there are different brands available, and different companies use different kind of technology to give NIV. And the machine in general is called bilevel positive airway pressure. So bilevel means both inspiratory as well as expiratory pressure will be developed. So just like PEEP we give in the ventilator or in the CPAP, here it is called EPAP, expiratory peak airway pressure, and IPAP. IPAP is inspiratory peak airway pressure. So I will like to show you a video of how a BiPAP machine helps. So this is a picture, a still picture of how ventilator is being used for giving a NIV. And this is the high flow nasal cannula. So this is designed by the Fisher and Paykel machine. And as I said, built-in temperature sensor to eliminate external cables, and it senses the temperature and delivers at right temperature. So humidification as well as right temperature is another big advantage of high flow nasal cannula. And there is a humidifier, and there will be a oxygen inlet, and this machine itself works as a blender. So if you all want to see how it works, how to use it, I would play this video. Otherwise, I'll skip this video. Hello?
Please play the video.
Okay, I'll play the video.
With setup complete, the EVO2 is now ready for your patient. The EVO2's power cord should be well secured to the rear of the unit before plugging into the mains utility power socket.
This is the machine we are using in most of the PICUs in India.
Switch on the EVO2 by pressing and holding the on-off button for 5 seconds. The unit will show you whether it is safe for use on a new patient. A green light indicates that the EVO2 has been disinfected correctly since it was last used. However, do not use the EVO2 on a patient if the orange light appears. You must dispose of the consumables and reprocess this EVO2 before it can be used. After confirming the EVO2 has been correctly reprocessed, you will need to adjust the patient's settings to match the treatment required. The current values are displayed on the summary screen: dew point temperature, respiratory gas flow rate, and oxygen concentration. Each value will pulse until reaching its set point. To make an adjustment, press and release the mode button to cycle through the set point screens until you reach the desired option.
This is the way we set the settings.
Selecting the right dew point temperature will provide more comfortable and effective treatment for your patient. A dew point close to body temperature at 37 degrees Celsius is recommended, though you may like to reduce the dew point temperature if the patient complains that the gas temperature is too warm. Press and release the mode button repeatedly until the target dew point temperature is displayed. This padlock symbol indicates that the setting is locked to prevent accidental changes. Press and hold the up and down buttons for 3 seconds to unlock the setting. The lock will disappear and be replaced by an arrow showing the minimum and maximum accessible settings. Press and release the up or down button to choose the new setting. When you have finished, press and release the mode button to lock the setting again. The lock will reappear. After 10 seconds, the EVO will return to the summary screen. The current dew point temperature will pulse until it reaches the new target. The respiratory gas flow rate can be adjusted the same way.
So as you can see, usually by nasal mask or nasal cannula, we give only 4 to 5 liters. More than that, we cannot give because it causes trouble for the patient. Because nasal mucosa gets dried and the temperature issues come. But in this one, you can actually give good humidification and the temperature is body temperature. So you can set very high flow rate. So 30 liter per minute nasal cannula flow is going on and patient, mind you, is very stable and very comfortable with this. So once you use, you'll feel like there's nothing better than HFNC actually for mild to moderate cases.
Press and release the mode button again, or wait 10 seconds to return to the summary screen. For patients that require oxygen as part of their treatment, you can connect the wall supply to the oxygen inlet port on the side of the unit now. Make sure you push the oxygen tube firmly onto the never have oxygen flowing through the unit when the EVO2 is turned off. When changing the oxygen concentration, press and release the mode button repeatedly until the large oxygen view is displayed. Using a built-in oxygen sensor, the EVO2 reports the concentration of oxygen in the respiratory gas flow as you adjust the flow on the wall supply. Simply adjust the oxygen flow until the desired oxygen concentration is displayed. While waiting for the unit to warm up.
So here what happens, one thing I'd like to tell you is this: the oxygen flow, the flow rate you can set for the gas flow, and then amount of oxygen you give through that meter, that will determine the FiO2. You will get the reading of FiO2, but you cannot like ventilator have a switch to directly make the FiO2 to 30-40%. You have to just increase the amount of oxygen in your gas supply from the wall connected central oxygen to see how much FiO2 is getting delivered.
Fit the appropriate interface, ensuring the head strap is not touching the ears.
This is how it is fit for adult
The
patients.
NO2 can be used with a
Pediatric
variety
patient,
of
this kind of nasal
patient
cannula
interfaces.
comes.
Read the separate user instructions for the patient interface that will be used, including all warnings. When the ready for use symbol appears on the display, connect the patient interface to the heated breathing tube. Attach the interface to the breathing tube by simply pushing the two connectors together until you hear a click. The gas delivered will feel warm when the patient first uses the unit. This is typical. They should simply continue to breathe normally. Using an OptiFlow Junior nasal cannula, you must activate Junior mode. Press and hold the mode button for 5 seconds until the Junior mode symbol appears. The yellow tube will automatically adjust the dew point temperature and gas flow to safe limits for the Junior interface. The dew point temperature is limited to 34 degrees Celsius and the respiratory gas flow rate is limited to 25 liters per minute. To deactivate Junior mode, follow the same procedure. Hold the mode button for 5 seconds. As with any medical device, you may need to make adjustments to the EVO2 as the patient's condition changes. Keep in mind that the patient's breathing pattern can affect the fraction of inspired oxygen. For this reason, you should always use a pulse oximeter and adjust the oxygen flow rate to maintain the appropriate blood oxygen saturation in your patient. The EVO2 has been designed to be as reliable as possible and will automatically raise an alarm when a problem is detected. The cause of the alarm is shown on the display. Silence the alarm with the mute button. In this example, the alarm was raised because a blockage has been detected. Once the blockage has been found and corrected, the EVO2 will continue delivering therapy to the patient.
So I guess this one was clear, right? Hello?
Yes, yes.
Yeah. So actually, it's a very simple machine. And once you start using it is not very difficult to use it. And the nurses can get trained in a matter of like 5 to 7 days. It's very easy. And to change the settings also is very simple. So it is very comfortable. One of the most comfortable devices for the patient. So now actually, I am actually going to show you the BiPAP machine. So
Dr.
this is
Sandeep,
all,
Dr. Sandeep, 1 minute. As far as children go, how do you decide how much ml per minute do you give and what basis?
Okay, yeah, definitely.
That is an important thing.
Yeah. So 2 liters per kg is what we follow for first 10 kgs. Are you able to hear me?
Yeah.
2 liters per kg for first 10 kg. So suppose a 10 kg child comes, 1 year old with 10 kg. So we start by 20 liters.
Okay. And after that?
After that, I'll tell you. So 10 to 20 is 1 liter per kg. And then beyond 20, it will be 0.5 liter per kg. So, but beyond 20 kg, so suppose a 25 kg child comes.
Yeah.
So what I will do is 30 plus like 32 or 32, like first 10 kg, it will be 20. Then another 10 kg, it will be another 10. So 30 liters for 20 kg child. And then beyond that, per kg, it will be 0.5 liters. But this is let me tell you. Hello?
Yeah.
Yes, yes.
Did you got the calculation right? So what happens is this is very arbitrary. Arbitrary in the sense, it is just the flow. You have to see the patient, how much he's tolerating and how much he's comfortable with. So it is just to starting point, we kind of think of it like that, but you don't have to strictly adhere to it. Means it's not like ventilator that you have to keep that setting only. It is very flexible. So suppose 10 kg child comes and we start with 20 liter per minute flow, right? After suppose 20 minutes, I feel that this child is very comfortable and we can actually come down to 18 or 16 liter. I will reduce it. It is very simple. So you reduce the flow and see how the patient is behaving. If the tachypnea doesn't go up or if the patient is still comfortable, we can keep the minimum possible settings for that condition to help the patient. So it is very flexible machine. You can easily change the settings and see how it goes. It is not fixed numbers. This is a rough guide to set a settings, but then you can always adjust it according to your patient's comfort level.
And what about the nasal cannula sizes? They'll all be different, isn't it?
Yeah. There are different sizes. Once you buy na, that will come for less than 10 kg, 10 to 20 kg and 20, 30 kg. There'll be colors also, yellow, purple, green, and these are all there, different colors. So once you start using, there'll be also limits. So like suppose the green ones is the smallest one, so it will not be, purple one is the smallest one, so it will not be used for more than 10 liters like that. There's a guideline for that. So if you want, I can share that also.
Okay, that will be bad. Nice.
So this is very simple. Just follow the chart that this cannula can be used for this much only. So it is very useful. Today, my main focus was on to give you a guidance on how to use BiPAP machine. So I didn't keep in focus this one, but this is a very simple thing. Once you see, it will be very easy. It is one of the easiest one. Okay. And basically, this is called OptiFlow. The OptiFlow nasal cannula comes. Okay. Shall I move on to next topic?
Yes, please.
So this is a BiPAP machine. So there are NIV machines which are customized to give non-invasive ventilation apart from the ventilator machine which can give. Pardon?
You have to come on to full screen.
Oh, sorry. So apart from the so proper NIV means either you give through a BiPAP machine, the NIV customized machine, or you give through the ventilator, that is NIV proper. CPAP, HFNC, these are all kind of lesser in the support. So it is kind of other modes of NIV, but not proper NIV. Per se, if you say NIV, we mean that either you put NIV mode on ventilator or you use a specific NIV machine. So among the NIV specific machines, there are two kind of machines. One are very small portable machine like a box. Okay, the one you are seeing on your screen, this is Respironics ResMed BiPAP machine, and the other ones are just like ventilator V60 Philips come, which actually give you ventilator graphics like graphics on NIV also, but that is very costly. That is around 16 to 20 lakhs rupees per machine, and it is used in some of the ICU. I have worked in Manipal and Rainbow also, it is there. But this is the one which is most commonly used in all the ICU, and it costs around 2 lakh rupees, 1.5 to 2 lakh rupees. And it's kind of a very portable one. Even it is used for home NIV also. Some of the patients with respiratory distress or chronic lung disease, it can be used on home basis also. So some people like to call it a home NIV machine also. Okay. So this is a brief demo. It is in Hindi. The demo is in Hindi. If you want me to mute the voice and dictate how it is being used, then I will do it in English. Or if you're comfortable with Hindi, then we can play the video. So there is a button over here which you press to start the machine. Then the machine starts loading. So once the machine starts loading like this, it will show a screen like this, so where you actually start planning the treatment. So here it will ask for how many seconds you want to keep it open. So how many minutes? So you press on that. So basically I'll show you two buttons are there. This is the on button and there's the button. This is the control button. Okay. So when you press these two together, the machine will unlock. This lock will unlock.
Yes.
So here you can see this machine has few settings, very few settings. Something called IPAP, which is actually just like peak pressure on ventilator, means maximum pressure during inspiration. EPAP is just equal to what we call CPAP. So in CPAP is what? During the expiration, whatever pressure is maintained from outside, that is called CPAP. So CPAP, EPAP, PEEP, all are actually synonymous, depending on which machine you're using. Then backup rate is the rate which actually it will be given, like if the patient is not breathing, this much rate will be given. Otherwise, the CPAP machine or the NIV machine actually works on the patient's own respiratory drive. So whatever patient pulls effort, it will synchronize and it will give the breathe of certain amount of pressure to help the patient breathe. And this is the pathology. So here you can actually adjust normal, then restrictive pathology, obstructive pathology, like that, or obstructive sleep apnea. So 4 modes are there. So normal is a disease where the lungs are normal. Suppose a GBS patient you are ventilating, then this will be a normal mode. So you don't have to change this. But suppose some patient with like pneumonia or consolidation, then you have to put restrictive. If you are doing for bronchiolitis or asthma, then they'll come obstructive mode. So this is the pathology. Then this modes I'll explain. What is ST mode, T mode, and spontaneous mode. So ST is spontaneous oblique timed, T is only timed, and S is spontaneous mode. So these are the modes, and there is a CPAP mode also in this machine. So these modes I'll explain a little bit later. So just go through, see what he's showing.
Mode है, ST mode, T mode, F mode, S mode, and CPAP. हम ST mode पे इसके बाद आप iPad पे आते हैं, इस बटन को गोल घुमाएंगे तो ये iPad पे आ जाएगा, फिर क्लिक करेंगे तो इसमें आप ट्रेनिंग कर सकते हैं जितने की आप ट्रेनिंग करना चाहें. हम सपोज करके हम 14 रखेंगे इसको, ओके कर देंगे. फिर इसके बाद आप कीपैड पे आएंगे, कीपैड हम सपोज करके 6 कर देंगे, घुमाएंगे तो चेंज होता रहेगा, 6 कर देंगे. तो इसकी ये सेटिंग हो गई. अब लॉक करने के लिए दोबारा दोनों बटन को दबा ये लॉक हो गया. ये सब मैन बटन है जिससे ये मशीन ऑन होगी. इसको दबा देंगे तो प्रेशर ऑन हो जाएगा. बस को दोबारा दबाएंगे.
So this is the machine. There are few settings. I'll try to explain the settings now. So what is IPAP? IPAP is inspiratory positive airway pressure. That is like during the inspiration, the machine will deliver certain amount of pressure to deliver the gas. So whatever the patient's lung has pressure, on top of that certain amount of pressure will be blown. So because of the pressure gradient, the gas will flow in the respiratory system. So that is called positive pressure gas delivery. So what it will do is it will provide certain amount of tidal volume to ensure adequate ventilation, and it also takes over the workload. So when our body is breathing, our respiratory system has to work to generate the negative pressure to take the air in. Here what is happening is by a compressor, the pressure is being given in the respiratory system by the machine to push the air. So what happens, the respiratory muscles have to not work that hard. So that is the advantage of having an IPAP. And it reduces the thereby dyspnea. So that is one thing. The other thing is EPAP. So what is EPAP? EPAP is expiratory positive airway pressure, or CPAP, continuous positive airway pressure, or PEEP, peak in expiratory pressure. So all these things are synonymous. There's no difference between these. Just because you use CPAP machine, you call it CPAP. When you use BiPAP machine, you call it EPAP. When you use ventilator, you call it PEEP. So there's not much difference. Can you see here? I may show you here. So you can
Sandip, make it full screen. Make it full screen.
Oh, sorry. So can you see here? PEEP, CPAP, EPAP, all are same things.
Yes. 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 Sir.
Okay. So these are all PEEP, CPAP, EPAP is the end expiratory pressure to keep the alveoli open. So whatever alveoli should not collapse at the end of expiration. For that purpose, we have PEEP, EPAP, CPAP, same thing. Okay. The other purpose is when you increase PPAP above physiological level. So normally in our airways, PEEP means the end expiratory pressure is around 3 to 5. But when we increase it above certain levels, suppose you make it 8 or 10. So what happens is in a pathological lungs, some alveoli will be collapsed because of consolidation, inflammation, or whatever the airway obstruction. So those alveoli will start opening. So which is in other terms, we call it recruitment. Recruitment means these alveoli which were collapsed and atelectatic, they were not taking part in air exchange. So now by opening them up, we are recruiting them. We are using them for air exchange. So that is the role of PEEP and CPAP. Okay. So this is the more like in ARDs and all, this is the main role. So in COVID also, we try to maintain the PEEP to open the consolidated or blocked alveoli. That is the role. And what the IPAP does is, IPAP is the pressure which maintains the airflow, the tidal volume. So each time when the breath is delivered, some amount of gas has to enter to inflate the lungs. So that is the role of IPAP. So here is a very, So here is a nice line. So we shows EPAP is 4 and IPAP is 12. So IPAP minus EPAP is the pressure support. So this pressure support determines the tidal volume because this is the pressure difference. So EPAP is maintained throughout the breathing cycle, and then extra pressure comes during the inspiration that drives the tidal volume. So tidal volume is dependent on the pressure difference between IPAP and EPAP. Okay, here also see pressure support is equal to IPAP minus EPAP. Clear now? Okay. So now what I had told earlier, that I will actually come to discuss about the different modes of BiPAP. So the AVAPS mode is somewhat intelligent mode, which we usually don't use, but the commonly used mode and the most common used mode is spontaneous and time mode. So what is spontaneous mode? Spontaneous mode is something where the patient is actually breathing on his own drive. Patient is initiating the breathe and the machine is recognizing that. How does the machine recognize? When patient tries to breathe, he will draw some air from the circuit in his lungs. So there will be a negative pressure. So that will trigger the machine, and machine will now give the set amount of pressure. So pressure has been set. The IPAP you have set. Suppose you say set a pressure of 10. So 10 centimeter of water pressure will be delivered from the machine through the interface to the patient's lung. So that is called IPAP. So what happens is, in spontaneous mode, patient has to trigger the machine, has to tell the machine that I want to breathe. But the work has to be not done by patient. The machine will give the positive pressure to patient to breathe and have the tidal volume. Okay. Similarly, EPAP is during the expiration, the certain amount of pressure will be maintained in the circuit. So the lung alveoli will not collapse. That is spontaneous mode. So expiration is not different in all this mode. Only the difference is the inspiration difference. Now time mode is what? Even if the patient is not breathing, if you set the time mode, what will happen is there will be a backup rate. So backup rate is like, if you set 20 means every 3 seconds, 20 per minute. If you set the backup rate, every 3 seconds, one breathe will be delivered to the patient, irrespective whether patient is triggering or not, whether the patient is able to initiate his own breathe or not. Patient will be getting breathe every 3 seconds. So what has happened is, this is very useful. The time mode is very useful for patients who may have something like obstructive sleep apnea. So they go into apnea intermittently. In that time, this helps as a backup. So sometimes patients stop breathing, the machine will give breathe and maintain the ventilation and oxygenation. So both the benefits are combined in spontaneous time mode. That is called ST mode. So ST mode, what happens is, it will let the patient breathe on its own. Suppose a patient is breathing at 40 per minute, it will actually give support for 40 breaths. But suddenly, if the patient stops breathing, the time mode will actually kick in. That time, mode will take over and will give you whatever the backup rate, like I showed in the previous video, that backup rate will be delivered. So usually we use ST mode as a default mode because it has the advantage of both the modes. CPAP mode is for milder disease, just like we use for in our NICU CPAP. So this also will give only expiratory support. So it is used in very mild disease where we don't need any inspiratory support. So this is CPAP. CPAP is very basic. We all know about CPAP from the very MD level. The problem with sometimes NIV is there will be difficulty in inspiratory trigger. So to trigger the machine, the amount of flow which has to be generated, the initial amount of patient's effort, that is sometimes very less. So it will become a problem. So that's why we say that NIV should be used in only conscious alert patients who have their own respiratory drive. Those patients who don't have their own respiratory drive, who are unconscious, we cannot use NIV on them. Okay? And sometimes mask is fit around the face and it can cause leaking, so which can cause a lot of problems in machine sensing. So now I'll just discuss about a little bit about, suppose somebody you have put on NIV, how do you know the NIV is working? So this is basic. That once the positive pressure is delivered, the patients get comfort and the lungs start opening up. So their respiratory rate will decrease. The amount of retraction and accessory muscle use will decrease. The airway occlusion events will decrease in case of obstructive sleep apnea. The oxygenation will improve in the terms of gases and SpO2 numbers. As well as X-ray, you will see that more of the area has become dark. So from white is consolidation in X-ray, and when you open up the alveoli, more of the areas will now be aerated. So you see the lung expansion happening in NIV. So this is how you understand that your NIV therapy is working. So contraindication to NIV, like I said, because machine is very, it is just dependent on patient to trigger the ventilator, and the time mode is not an independent mode. In that way, it will not totally support for a very long time. So you cannot put patients of apnea or who has very poor respiratory effort on NIV. So that is one most important thing you should remember. Unconscious patient or patients who don't have their own respiratory drive, you should not put on NIV. Then same thing, that is the poor GCS, less than 8 GCS, NIV cannot be used. Patient who don't have gag and cough reflex, they cannot be used in NIV, because it's once you put face by mask, what happens is if the patient cough, if patient is having an aspiration or vomiting, it will get into the airway. That can cause problems. Then excessive secretions also make the NIV ineffective. Then there are some patients who cannot actually like the mask, so they will become agitated, uncooperative, or the mask fit is not good. That is a problem. Very sick patients you cannot put on NIV. So from the very beginning, I told you mild to moderate patients only should be put on NIV. Very sick patients, it is not a robust support. Like invasive ventilation, you cannot regulate everything very strictly. So it is very difficult. Then upper GI bleeding, like I said, because you put air across the nasal and oral interface, so the pressure is transmitted and it can go to the GI system also, because there is no distinction. You are only putting from the nose and mouth. So there, behind that, there is oropharynx, there is nasopharynx, both is there, and one leads to larynx and other links to esophagus. So the pressure will be transmitted to esophagus also. So in that sense, in patients who are having upper GI bleeding or upper GI surgeries, it is very difficult to put on NIV. So the same thing has been written in this point. So recent gastric, esophageal, or upper airway surgery, NIV is not to be used. So then what are the reasons to discontinue NIV? So what I mean by discontinuing NIV is, suppose a patient comes to you in mild to moderate illness and you try NIV. About 50 to 60% times you will be successful and you will avoid an intubation, which is a big thing for an intensivist or a doctor who is working in PICU. To avoid intubation is very good for patients. I said earlier also, it reduces the patient discomfort, it reduces the risk of infections and ventilation induced in lung injury, and a lot of other problems and cost also, and hospital stay. But there will be instances where the disease process may progress, and from mild moderate it may go to a severe state wherein patients may not be having enough support from NIV and patient may have respiratory failure. So for these patients, how do you identify? These are the patients who will have not enough oxygenation on ventilator, so persistence of hypoxia, the tachypnea, the respiratory distress, the workup breathing is not normalized. That is again a problem. There are patients who are continue to be on hemodynamic instability. That is the main problem. Then if the patient having too much secretion, sometimes there will be patients, subset of patients who will be having too much excessive secretion or vomiting. They will be unsafe for NIV because they have very high risk of aspiration. And then patients who are very agitated or having poor mental status. So if any patient on whom you have started NIV and you are not able to continue because of these reasons, you have to go for intubation. Okay. So now coming to summarizing what are the advantages and disadvantages. So advantage of invasive ventilation is you are securing the airway. So invasive ventilation means endotracheal intubation you are doing. So then you are securing the airway and there is very less leak in invasive ventilation. When you put airway ET tube, when you inflate the cup, there is no leak. So there is no disturbance. You can control the pressures very well. Then there is facilitation of secretion movement. You can always do ET suction. In NIV, it is very difficult. But the disadvantage is whenever you intubate, you cause trauma to trachea and it requires sedation, muscle relaxants, risk of VAP and other problems with NIV. As I said, prolonged hospital stay, ventilation-induced lung injury. So there comes the advantage of NIV. The NIV doesn't put you at risk of nosocomial infection. It improves the patient comfort because patient is awake. And if you use a nasal interface, then you can feed the child from mouth. That is the advantage of NIV. That is how good NIV is. You don't require any sedation or minimal sedation may be required initially for a child to get adjusted. So in pediatric patients, what we do is we give small dose 0.5 mg ketamine just to keep the child calm for a very brief period till they get adjusted with the NIV. Okay, and it is less painful and you can do early weaning. In the sense, if you put on ventilator and your child is requiring only mild to moderate settings, you can wean the child on NIV and continue NIV for 1 or 2 days. So that will be more effective rather than just continuing with NIV till the whole pathology resolves. Okay, so now coming to the more practical part of using NIV, there are how many types of NIV masks are available. So I have put a few pictures over here and I'll selectively discuss all of them alone also. So there is nasal pillow, there is nasal mask, so only around the nose. There's oral mask, there's full face mask, which is actually a oronasal mask, and there's a total face mask which actually covers the eyes also. So in practice, I will tell what we use commonly is the nasal mask or full face mask, oronasal mask. The most commonly used is the oronasal mask. Nasal pillow in some settings in small children is useful. In my practical experience in many centers, we are only using oronasal mask. So this is a nasal mask. This is a nasal mask. You fit it around nose. The advantage with this one is actually patient can clear his secretions by himself only. He can cough, he can spit, and he can eat also if he's comfortable enough. So this is a nasal mask. This is a full face mask, or what we call is oronasal mask. This is the one we actually use. The good thing with this is, like here, the air can leak from mouth. In oronasal mask, there is very less chance of leaking of the pressure from the mouth. So this is the one which is commonly used in pediatric ICUs. Total face mask, frankly, I have not used, and it is a little bit uncomfortable to have your full face covered with the mask, even the eyes getting covered, because you don't require pressure around the eyes. So it is very less used in common practice. Nasal pillow or nasal prongs is just like how you use in your NICUs. So there's nasal prong to deliver CPAP, right? So same thing is can be used in NIV also. But there's always a problem, like in CPAP, what happens? The pressure you put in the airway gets leaked from mouth. Here also the same problem happens. Nasal pillow is same like a nasal this one prong, but it is fitted more snugly. So you can see it is designed in such a way that rubber actually fits and blocks the nostril, and it is a device which is more specifically used for obstructive airway disease patients, like those who have sleep apnea syndrome or these are all problems. So like this. So it is not commonly used in ICU as such. So in a comparison, if you see oronasal and nasal ones, oronasal has better control of mouth leak and it is better for mouth breathers. The only disadvantage is sometimes it is claustrophobic and it has a very high risk of aspiration. When you patient vomits, because mouth is under the cover of mask, it can go to the airway. Difficulty in speaking, you cannot speak because your mouth is covered. And if the ventilator malfunctions, then you don't have any of the, either nose and mouth both are blocked. So somehow, suppose power connection goes or something happens, the NIV stops working, means you are totally sealed. You cannot get air from outside. Whereas in nasal mask, if your nose is blocked, you can breathe through the mouth. Okay, so this is the thing about oronasal mask. Nasal mask, because only the nose is covered, less risk of aspiration, whatever the secretions or vomiters can be coming out from the mouth. And similarly, you can do suctioning from the mouth, and you covered only the nostrils, so the less dead space and easier to fit. So disadvantage is, like I said before, mouth leaking happens and higher resistance is actually put through the nose. So sometimes people feel too much pressure in the nose. Okay, so all the pressure which can be distributed from the oral and nasal orifices is only put on the nasal, means sometimes people feel there's too much nasal pressure. So that is a little bit uncomfortable for many patients. So this is how to use the interface, how NIV interface is applied, how it is used. So what I actually didn't tell you earlier is there can be mask with vent and without vent. So when you use a BiPAP machine, the machine I showed in the video previously, they have only a single limb. So single limb can deliver the gas, but there's no expiratory limb. So in ventilator, you know, there's an inspiratory and expiratory limb. But in that BiPAP machine, there's only one limb. So it actually helps in delivering the gas. Then how does the gas come out? So there'll be sometimes small holes over here that is called vents. So the vented masks are actually used for BiPAP machine, and non-vented mask is used for if you are using the ventilator for delivery, because that has an expiratory limb. So air can escape from the expiratory limb. So vented mask for the NIV machine with BiPAP, and non-vented mask for basically the ventilator deliver NIV. So both are available. And three sizes they come in: small size, medium size, and large size. How to measure the size of the interface, that is also shown in this video. So there are straps. So one strap is actually fixed around the head and the forehead. This kind of a stabilizer thing is there, and which around the strap you can put on, and there's another around the ears it goes, and both the straps are tied behind the head. So there will be it will be tied. So the good thing with this is you can put it, and if you see the patient is feeling uncomfortable for half an hour, 15 minutes, we used to give breaks. How we used to do is we can give 4 hours continuously NIV, and then for half an hour or 15 minutes, just give break for the patient to feel relieved, because sometimes patients feel too much pressure around their mouth when we put on this NIV. Okay. So the same thing, I think it helped the video. So how to apply NIV is basically choose the correct interface according to patient's mouth size. And I have to tell you, it is not always a perfect fit, because it comes in small, medium, and large size, and human face is not like only 3 sizes, right? So different size will be there, and you have to little bit make adjustments and make peace with a little bit leaking. You have to apply some gauze and all between the surface of the interface to make it work. And we have something called a thermoseal, which actually is kind of a gel material which prevents pressure source because of the NIVs which we use. Okay, so first of all, before putting the interface, you need to talk to the patient. In our case, children, we have to convince them that this is very going to take away the difficulty in breathing for you, or the distress you are having. And initially, we start by giving a very less pressure and keep it around the mouth, and don't actually apply the straps. So initially, just keep around the mouth, let him get adjusted to the air blowing in his orifices, and then slowly attach it and put. And then what we do is, first we set the ventilator in ST mode. We usually don't use only spontaneous or only time mode. We commonly use ST mode because it has both the benefits. And we start with low settings. Like I said, people don't like that many high flow coming around their nose and mouth, so they can get irritated because of that. So we start low, somewhere around IPAP of 8 and EPAP of 4, and then slowly increase based on the needs. Okay, hold the mask with hand over the face. So we don't initially apply the strap. What we do is keep the mask on the face and let him get adjusted. Let him get breathing with the mask around his face, and a little bit comfortable, and feel that it is helping it. Then the child will let you allow to put straps. If you directly go and apply strap, child will get very irritated and frustrated, and he'll immediately remove it. So that's why we need to give some time. We use actually 15 to 20 minutes just to get the child adjusted with it. Okay. So increase the EPAP by 1 to 2 centimeters. Don't initially make the EPAP more than 4. Slowly you can make 6 and 8 once the patient gets adjusted to it. And if the patient is making inspiratory effort, ventilator is not responding, that means the patient's PEEP is not enough. So you can increase a little bit more PEEP. So patient's effort will be helped by the PEEP. Achha. So now start IPAP. So once the patient's retractions are improving, then you keep increasing the IPAP. So IPAP will increase the delta P. So tidal volume will be better. So you see at what point the retractions stop, that point you should stop. So usually we maintain the IPAP. Hello? So IPAP is usually maintained between, initially we start from if you have set the EPAP 4, then you set the IPAP 8, and then slowly increase the delta P by increasing the IPAP. You can make it 4 upon 10, means the delta P will be 6. Delta P means the difference between the pressure, which actually is the pressure support. So that will help the patient increase the tidal volume. Difference in pressure drives the gas. So that will be determining the tidal volume. So that is what we do. and slowly we can set the eye time according to the normal eye time of the patient, then apply the strap and monitor oxygen levels like SpO2 and see the child's sensorium, the workup breathing, the tachypnea, the tachycardia, all these things we have to continuously monitor. So among the did I tell anything? So among the common complications of NIV is basically when you apply this oronasal mask or nasal mask, it puts a lot of pressure between the interface and the skin. So there can be skin erosions. And mind you, it is very, very common. So in Corona also we saw by simply applying the the N95 mask, people got scars and erosions in the face all over the world. These kind of pictures came for caregivers that they were applying an N95 mask and they got rashes, scars because of that. The same thing, imagine putting a mask with so much pressure, it can cause nasal erosions. And sometimes what happens is NIV machine, patient if stops breathing, the NIV machine is not good enough to support for a very long time. For short time, the time breath will come, but it will not maintain adequate ventilation for a long time. So that is a big concern regarding the NIV. Another problem is if the patient vomit inside the oronasal mask, you saw that it is a closed system, so it will go to the airway. So that is a big problem. So aspiration is a big risk. And there, because it is putting pressure both in the nasal and the oral cavity, so gas pressure in the oral cavity directly gets transmitted to the esophagus and stomach. So abdomen distension can happen. That is a big problem. That's why when you put a patient on NIV, you usually put a NG tube to decompress the stomach. Otherwise, the patient may have pain because of stomach distension. So finally, we have arrived to an algorithm. So this is a common algorithm. It was published in Clinical Journal of Respiration. So in this kind of a basic guidelines as to how to use NIV in COVID. So we usually use for patients who have PF ratio less than 200 and target to get a tidal volume around 5 ml per kg. So tidal volume is a measured setting you can get in NIV machine. So you will get around, you want to target around the low tidal volume strategy like what we do for ARDS, 5 to 6 ml per kg tidal volume. And pressure support, like I said, that is the delta P, IPAP minus the P, or the IPAP minus the EPAP. So you start somewhere around 4 to 8 and then gradually can go up to 20, and PEEP around 8 to 10 is what we try. So initially we start 4 PEEP and then slowly 6 and 8 we try to achieve to recruit the lungs, because in COVID what happens is a lot of lung consolidation happens and the alveoli are collapsed and athletics has happened. To open those alveoli we need PEEP. So FiO2 usually if you have mild to moderate hypoxia you will start 60% and then adjust accordingly. Because see, if your child is requiring FiO2 of 100%, that means the child is very severely sick, and severe ARDS, NIV will not help. I have repeatedly told NIV is for mild to moderate children, not very sick patients. So after 2 hours is just a brief guideline, but you can do it after 1 hour also. What is actually required is the ABG. You see the patient's respiratory rate. By patient comfort, we mean the amount of retraction, the workup breathing, the use of accessory muscle to see and see the parameters. So if there is an improvement in oxygenation, both in terms of SpO2 or PaO2, and the respiratory rate has come down or the workup breathing has come down, then you can continue to be on NIV for some time. And then once you see that the patient lungs are actually disease process is healing, then you can slowly switch on to HFNC or another face mask, simple face mask. That is the way it goes. But if there is worsening on NIV, then you have to go for endotracheal intubation. The signs of worsening or failure of NIV, I have told, that is the increase in workup breathing, not achieving the desired amount of oxygenation, or you are having altered sensorium, vomiting, all these problems, or excessive irritability. These are the things that your NIV is failing. So then you need to do intubation. Or this is the one algorithm. The other algorithm is after applying NIV, again the same times that the patient is not improving, like the SpO2 is less than 88%, rates are increasing, PCO2 buildup is there, means hypercapnia is happening, acidosis is coming. So that means the NIV is not working. So you can increase the NIV settings initially. You can go up to IPAP of 20 and PEEP of 10 or 12. But even after this, if the patient is not improving, then you have to go for ventilator. So in summary, NIV offers support for acute to chronic hypercarbonic respiratory failure, means where PCO2 is built up by increasing the PS. For acute hypoxemic respiratory failure, in only mild to moderate cases, it is helpful. It is a very helpful tool to avoid intubation in immunocompromised patients, like intubation puts the patient on risk of VAP, and then you can get severe illness. So to avoid intubation in immunocompromised patients, especially in the unit I am working, we are having DMT patients who are the most immunosuppressed, or the liver transplant patients. So in that case, or immunodeficiency patients. So in that case, we use NIV a lot to try to prevent intubation. Then post-extubation, if the patient is having increased work of breathing, though you don't need to re-intubate, you can just put on NIV, or sometimes what we do is we extubate and put directly on NIV. So these are the benefits, practical benefits of NIV. So in summary, in pediatrics, mild to moderate hypoxia patients, put on NIV early than late. The patient deteriorates, then it will be too late for the patient to get a benefit from NIV. So there's one study, this is the same study which they use this protocol. So they found that almost 48% patients were successful to be managed on NIV. So who had PF ratio less than 200, they used about 70 patients, and they found like 48%. So this is around 50% of patients actually they were able to manage only with NIV, and they avoided intubation. And 26% of the total patients actually required intubation. So this is a very like practical way of looking at the role of NIV in COVID. These are all COVID patients. The study I have quoted is the COVID study, and they have used it on 75 patients about. So they have found almost like 50% patients were only managed with NIV in a very nice way. And some of the patients who failed, they are around 25%. And then they saw that patients who were initially put on NIV and those who were not put on NIV, they have same amount of mortality. There was not higher mortality with doing NIV. Some may think that we are, by giving NIV, we are delaying intubation and delaying definitive treatment, but that is not how it is. In mild to moderate cases, NIV actually may support the patient better, and you may get away without doing intubation. So that is how it is very useful. So now I'll be open to ask any questions. You can have that session.
Hear me? An excellent talk, Dr. Sandeep. Very, very useful. I have a few questions before I open it to the audience. One is most of the NIV masks will have some amount of leakage. So how much, and the machine shows the amount of leakage that you have, most of these BiPAP machines. So how much leakage do you think is acceptable in pediatrics?
Okay, so there are two answers to this. One is theoretical answer. We go by 20% leakage is acceptable. But in practical, I have worked in units where we have very high leaks. And what we have made sure is patient is comfortable, patient is not having high work of breathing. The amount of rates, the respiratory rate is good. What we want to give is not very high. Means like normal physiological rates, it is maintaining. Oxygenation and PCO2 levels are okay. Once these things were okay, sometimes because of the lot of limitations are there, we don't have always the perfect fit NIV mask. We don't always have the perfect fit machine also for the patient. So there are a lot of limitations. Then you learn to work around those limitations and see that patient is comfortable, the respiratory rate is good, the oxygenation and PCO2 levels are good. Then you just avoid thinking too much about the leaks and all. As long as patient is not complaining, patient is trying to improve. So these are the things. But one thing is, when leak is happening, you'd be very cautious that the patient is not deteriorating. You don't miss, just because leaks are there and you are ignoring the leak, should not miss the patient deterioration, because sometimes this patient will deteriorate and you may need to ventilate and support in a definitive way. So that is the most important thing. When you have a leak, you should take care.
And how does oxygen go inside the system in a single tube mask over here?
So what do we do is, this machine, I showed the machine, respirant machine, it has a port for oxygen. So you can connect oxygen in that. The disadvantage with the respirant machine is it doesn't tell you how much FiO2 you're delivering. So you are not very sure how much FiO2 you're delivering. When you're delivering NIV by mechanical ventilator, you know how much FiO2 you're giving, because machine will show, NIV ventilator will show. If you have the Philips V60, that is the, I told the costly BiPAP machine or NIV machine, that also has a fixed FiO2 setting you can set and deliver that much. But this is the one, the ResMed one, no, the small one, the portable one, which you use in adult ICUs and pediatric ICUs, and it is a home NIV machine. In general terms, it is called the home NIV machine. The disadvantage is you don't know how much oxygen you're delivering, because you set 10 liter in your oxygen knob, but this machine has a very pressure delivered system, right? So how much flow is going, you don't know. You're setting pressures, you're setting IPAP. So you don't know how much flow of how much flow is going, and then how much FiO2 actually is getting delivered to the patient. That is the problem with the recipient machine. But we have seen it is a very effective way of giving, and mild to moderate cases, it doesn't matter. If you just keep 10 to 15 liter of oxygen in your oxygen connected with the tubings, it mostly works out.
What about feeding during NIV?
Feeding during NIV, it is very cautiously to be done, and in a selected patients only, and it has to be done by people who are very confident of their NIV skills. Reason being, like I said, because the pressure is getting delivered both around nose and mouth, all the pressure gets transmitted to the esophagus and stomach. So there is a stomach distension. You can avoid doing that by putting an NG tube. So you feed by NG tube, suppose, then how do you provide gastric relief? Because the gastric is always getting filled with air. So what we used to do in the units I have worked is, you give feeds by the NG tube, and then you block it for only half an hour. And then after half an hour or 1 hour, you open it so that the continuous gastric decompression happens. This is how you used to work. But what I say is, if you are not confident, don't feed on NIV, because it is a very risky thing to do. You have to be very good, and your nursing care has to be very nice. There has to be experience gained in using NIV, then do feeding. That is the practical. This is the practical tip, actually.
Thank you so much, Dr. Sandip. I request Dr. Ravi Kumar now to open the questions for the other people.
Yes, sir. Thank you, sir. Sir, it was a very nice and elaborative talk. There are a few questions in the chat box. Dr. Suhasri Kar has asked, what can be the highest IPAP we can set? Highest IPAP.
See, in practical terms, you can set IPAP 20 and 22 also, right? In this machine. But you have to look at it in a different way. See, if the patient is requiring an IPAP of 22, that is corresponding to a ventilator setting of PIP, peak inspiratory pressure of 22. So that means that patient's disease severity has progressed to a certain extent. So it may be situations where you are going above 15 or 18. No, you start thinking whether this patient deserves to be intubated. In practical terms, you understand, because if you are delivering so high pressures through NIV, the patient lung may not be normal. It is gone from mild to moderate to the severe variety of disease, and there will be a lot of problems when you do very high pressure around the mask. It will be very uncomfortable for patients, and there will be leaks, and there are a lot of issues are there with that. So that's why I say that, okay, 15 to 18 is fine in practical terms, and beyond that, you can always look into whether you can go on ventilator. Now, if you have other concerns like your ventilator is not available, in COVID it has happened, right? We have been forced to do unnatural things. Resources have been limited. Then there's no option. You have to try higher things, and see what works for you in that particular situation, because situation always changes, and there's no hard and fast rule for everything. Okay, but you have to understand the science behind it and the practical concerns.
Okay. So tell me your experience regarding the first wave and the second wave of COVID. How it was difficult or how it was different from each wave. How did you prepare yourself for this upcoming?
Okay, so I'll tell you how it went through. So when we actually heard in India, 29th of January, I think the first case happened, and we had a meeting about NIV in COVID, about COVID on, I think it was 31st January, we had a meeting. It is the usual weekly meeting about academics we have, and we discussed about COVID, and we thought, okay, this may not be that big concern in India. It was that time only limited to China and some of the Asian countries, but mostly in Europe it was coming. Then it came to us, and initially we were very scared. The problem with COVID was we didn't know what will work in COVID. So it took almost like 2-3 months to figure out that steroid is actually working on COVID and when to give steroids. Because initially WHO told, I think most of you would remember that steroid is not to be used in COVID.
Yes, initially.
Then Indian people, actually people from India actually did a lot of work on steroid, and they actually now started timing the steroid therapy correctly, and then figuring out, okay, between this period, if you give steroid, the patient is actually getting benefited. Then the other drugs like remdesivir, tocilizumab, and a lot of things later it became very clear that when to use it and how it is beneficial. My personal experiences within the first pandemic, first wave only, my father got positive in July, and he got moderate like kind of illness, and I had to admit him in Kolkata. It was very tense and very scary situation because beds were not available at that peak of the pandemic. And for us in the first wave, I have managed to put central line and put patients on NIV in going into full PPE mode. So that we have done intubated. I actually in first wave intubated patients on NIV in period in COVID patients on who were COVID positive. So this we have gone through a full toll of this thing, but somehow we were okay. Some of the team members actually got COVID positive. First wave, what happened is most of the illness were mild illness. Children did not get very severe COVID lung infections.
Yeah.
All were a kind of incidental positive or mild, just like a bronchiolitis we used to manage with HFNC. Very rarely we used NIV, and we used only ventilator on 2 or 3 patients. That's it in the first wave.
Okay.
Second wave and first wave in between, nobody noticed, but pediatricians had another pandemic. We had MISC. After the first wave finished and the cases came down, we kept on getting MISC patients. For MISC, again, to use IVIG or steroid or both, that was a confusion. But then we figured out hemodynamically unstable patients, we were using both. And hemodynamically stable patient, either of the agents worked fine, depending on what cost they can afford. If alone steroid also works, alone IVIG also works. But hemodynamically unstable patients, we decided we'll give both. We could not take chances in such high settings where expectations are very high from us to treat everyone in a perfect way. So we could not take any chances. There are trials going on. We are part of a few trials, which is actually comparing steroids and IVIG head to head, as well as combination of both compared to these 3 modalities. So these are all going on. But practically what I would say, you are getting a hypotensive child with a MISC, you give both. If you have a patient of MISC who is partial MISC or not that sick, you can give steroid and IVIG based on the availability and cost issues. You always know that IVIG is much more costlier than, I think 1,000 times more costlier than actually steroids, right? So steroids are very cheap. Imethylpredate or dexamethasone, both are very cheap and they don't cost you much. But then IVIG is very costly in India, and sometimes patient may not be able to afford for children who are older. So some 50 kg children or 60, 70 kg children, it may cost around like a lakh or so. So that is how it is, practical reality. But in our setup, we have been blessed because there are a lot of things we keep on arranging, charity and all. So we are using IVIG very commonly.
I think the first, rather the first attack, we have to see the post-COVID complication like MISC. It is more dangerous than the primary infection, I think.
Yeah, you actually told the correct thing. So in pediatrics, we never got so severe lung infections. Second wave, I got a few patients we had to intubate and manage. But MISC was the bulk of the work we have done in terms of COVID.
Okay. So in that case, the respiratory failure in case of MISC, what was the prime modality of ventilation? Either it was NIV or invasive.
MISC doesn't affect the lungs in that way. It is not causing alveolar constitution. It is usually causing interstitial edema. So for that, now just HFNC sufficed.
Okay.
95% of patients, we just did HFNC, and that also for 1 or 2 days. That's it. The moment you give steroids or IVIG, the inflammation reduces and it becomes very good in some time.
Okay.
Okay, Dr. Sandip, our teacher and Professor Dr. Leena Das thanks you for the excellent talk. She wants to know how patient will have experience on high flow ventilation.
High flow ventilation, you are asking HFOV or high flow oxygen device? HFNC, you are asking?
Dr. Sethi, you allow Dr. Leena Das to ask the question. Dr. Sethi, you ask Dr. Leena Das to unmute and ask the question.
Okay, Leena madam.
Yes, thank you. It was very excellent. I want to know that the patient will expire and inspire on the same tube to the machine or different?
In which one you're talking, madam? You're talking about the machine I talked here.
NIV.
HFNC. So there, see, in NIV, when you have an oronasal mask, I showed that there will be a vent, there will be a small hole in that through which it will come out.
Air will not go during inspiration.
No, madam. Try to understand. So when you're using a mask, either suppose oronasal mask or a nasal mask or oral mask, it has certain amount of holes. Okay. So during the inspiration, because the pressure is important, so
Yes.
pressure will create that gradient to air to flow, and it is too good to overcome that small hole.
Yes.
During the expiration, that hole will facilitate the CO2 to wash out.
There is a valve. There is a valve or anything.
Valve, no, there's a hole. I'll show you.
Only hole. Okay. Okay.
I'll show you a hole where it is. Yes. So I think I showed the interface. So this one now, there will be small holes here. Okay.
Okay. Yeah.
So there will be small holes here through which the air will escape.
Okay. Okay. Thank you.
But how about in HHFNC, Dr. Gupta?
So HFNC, nothing, very easy. So HFNC,
Yeah,
what happens? Just like a nasal cannula, what we ensure in HFNC, I'll tell you. Wait.
See,
So,
my question is,
okay,
we are
let me
giving
stop
flows
sharing.
of
So
20 to
HFNC,
30
what happens
liters.
is there are two nasal cannulas in the nose, just like prongs. Okay. So we ensure that the diameter of the cannula or the prong which we are putting is less than the 50% of the nostril size.
That is true.
So their way it will come out from that gap only. It is
But
not
even if
snugly fit.
See, even if you are giving flows of 20-30 liters per minute, then also there's enough space way for the expired air to go.
Yeah. So it works in that way. So when you give 20-30 liter flow, what will happen? It will create pressure. So with that pressure, it will come out.
Okay. Thank you so much.
I think this is the list of questions. Any more question? I don't think that.
No, we want only to thank you for the webinar, and both have because you have covered both the basics and a high tech deliberation like this NIV. And many I wish that in future you will do many more webinars and we will join. Thank you, Dr. Seth. Thank you, Badabai, that my young brother.
One more thing.
Thank you.
This mask is of different sizes. No, how many sizes are there?
So in what happens, madam? It is usually said to be small size, moderate, medium size, and large size. So that is how it comes. And I am telling you very frankly that we use oronasal mask. We don't use nasal alone, mask wise. Okay. The thing
for a newborn, the mask is also there.
Yeah, it is there. It is mainly so for newborn. Actually, what happens? There is a different mask. It is like only in newborns is one case where we use only nasal mask. I say we don't use nasal. So in pediatrics ICU we don't use, but in smaller infants like less than 6 months or say newborn, there comes something called a nasal mask. I think it can be same mask which is used for CPAP also. I think you would have seen. Apart from having a prongs for a CPAP machine, there will come some mask, nasal mask. I think you would have seen Physiotechnical ka aata hai. So that one you all would have used in NICU. The same thing can be used for NIV also.
Okay, thank you. For this third wave preparation, we need to bring all this mask and everything, prepare for that. For that only I am asking.
Sure, madam, sure.
Yes.
Okay, thank you.
Thank you, Dr. Gupta. It was a very, very excellent presentation. You told very basic things. It will be very helpful even for the general pediatricians. Thank you so much for delivering this nice talk.
Thank you, dear sir.
Dr. Sethi, you can take over and give a vote of thanks to the speakers.
Dr. Prasanth sir, you want to say something more?
No, I have already ventilated my feelings, and I'm really thankful. I don't think my time wasted. My time is valuable, and I also learned much more things, many more things, and especially I am grateful to Dr. Gupta, who was deliberated in such a nice way that even if I am not interested, even I am not doing this NIV. So I got all these things. I told Lina madam because she is an administrator. She wanted to know everything about the apparatus. But I wanted to see how the procedure is done. and I could learn how it is difficult and how it is given in the for the NIV in the ICU setup. And many more thanks. My heartfelt thanks to Dr. Gupta and also to Dr. Halwai, who has given a very good presentation in skin infection, and that is also much more very beneficial for the grassroots pediatrics. And hats off to you, Dr. Bhuya, my elder brother, and Dr. Sethi, and my younger brother. Jite raho dono.